Welcome everybody to the Health Law and Ethics Network at Melbourne Law School. My name's Professor Paula O'Brien. I'm one of the directors of the Health Law and Ethics Network, along with Dr. Chris Gingell from the Murdoch Children's Research Institute. I'd like to start by paying my respects to the Wurundjeri people of the Kulin Nation, the traditional owners of the land on which Melbourne Law School stands, and pay my respects to elders past, present and emerging. And I very warmly welcome any Indigenous colleagues who are with us today. Each month, the Health Law and Ethics Network hosts a research seminar that profiles research that's occurring in the health law and ethics space across the university, with a focus on legal and ethical issues, but very much bringing an interdisciplinary perspective. This month, we're very, very pleased to welcome our colleague, Professor Stuart Kinner, to the seminar, who will be presenting with Miss Tess Kelly. Stuart is a Professor of Health Equity at Curtin University and head of what is called the Justice Health Group, which spans Curtin University, the University of Melbourne and Murdoch Children's Research Institute. And he's joined by Tess Kelly, who is a Senior Associate at the Correctional Association of New York. And today they're going to be presenting their seminar on ensuring the highest attainable standard of health for children deprived of their liberty. Tess and Stuart will speak for about 35 minutes. And then our colleague, Professor John Tobin, who is an expert in human rights law, particularly children's rights and the right to health, will offer some comments and a segue into the Q&A time that we have with Stuart and Tess. So we'll make a start, and just a very warm thanks to Stuart and Tess, who are in New York at the moment. It's very late there, and so we really appreciate them joining us for this Helen Lunchtime seminar. So over to you, Stuart and Tess. Thanks very much.
Thanks very much, Paul. I appreciate the welcome, and thanks, John, and everybody else who's involved. And apologies in advance for any car noises outside. This is New York. Thanks for this opportunity, and thanks very much to Tess for joining as well. Really, this was work that couldn't have proceeded without Tess's expertise and energy. So we're thrilled to be working with Tess on this project. And as Paula said, I'm going to share some slides and talk as quickly as I can, and then hand over to Tess to finish off, and then hopefully on to John for a few reflections and then some conversation. But look, given that it is a fairly small group, if there are any comments or questions throughout, I'd be really happy to if anybody just wants to unmute or interject or turn on your camera so that we can see who these put some faces to these names. That'd be great. Okay, look, so I also want to just acknowledge Alex Campbell, who played a fairly pivotal role in this work as well. Alex is appointed across the University of Melbourne and MCRI, and Alex did a lot of the work to help build this project together. So thanks to Alex. So just to give you some background, our group had the opportunity about 5 years ago now to contribute to what was called the UN Global Study on Children Deprived of Liberty, which emerged from a UN mandate a number of years prior to that, that was intended to look at the situation of children deprived of liberty around the world in all contexts. And when we first got connected with this global study, to our surprise, there was no focus on health in the study. So it was a focus on the quote unquote situation of children deprived of liberty, but with no explicit consideration of their health needs or of the health services delivered to children in those settings. So it was a very large project. If you want to download the 700 odd page report, it is an interesting read. There's an executive summary for anybody who's busy. The headline, of course, is that, as you can see, there's an conservatively estimated 7.2 million children de facto deprived of liberty globally each year. And that includes around 1.5 million children effectively deprived of liberty in criminal justice context, including 410,000 each year in youth detention. And so what Tess and I are going to focus on is those children, the 410,000 at least children who are deprived of their liberty in criminal justice settings each year around the world, including, obviously, but not limited to Australia. So For some background, this paper by Nathan Hughes that flowed from our work on the UN Global Study looked at some of the health-related drivers of contact with the youth justice system, and really in a very comprehensive way, it made the very simple point that children who have contact with the youth justice system are distinguished by a high prevalence of complex health and health-related concerns. And of course, the criminal justice system, including the youth justice system, effectively filters for those children. So whether or not that's the intention, that the effect is that children with mental disorder, with developmental and neurodevelopmental disabilities, children with mental illness, children who've experienced trauma and other adverse childhood experiences are much more likely than other children to end up in the youth justice system. So there's this enormous concentration of burden in these settings. And the parallel paper led by Rowan Borshman, who's a professor at Melbourne Uni as well, showed that when children do end up in youth detention, not surprisingly, there is an extraordinarily high burden of complex co-occurring health and health-related concerns. And I think the complex and co-occurring is really critical here because it's not just mental illness, not just substance use disorder, not just neurodevelopmental disability. It's the fact that the co-occurrence of these conditions is normative among these children that necessitates a very increased level of coordinated care. So the UN Global Study was a very large initiative. It took about 5 years, and there were research groups around the world involved. If I can try to summarize these 700 pages in one slide, the key recommendation, as you might expect, was to reduce the number of children in places of detention, to really put our action where our words are with respect to using detention as a sanction of last resort. So reducing the number of children in places of detention, including in youth detention. Recommendation 11 was one that we were very pleased to see included in the final report. It's something that emerged directly from the health chapter that we contributed to that report. And recommendation 11 is that health services in detention shall be of a standard equivalent to that available in the community at large. Now, that might seem really obvious and banal, but hopefully during our seminar today, we'll explain to you why it's also very important. Because one of the reasons it emerged that this is important is because there's a strange and perverse tendency for advocates who are focused on reducing the use of deprivation of liberty for children, advocates who are focused on not having children detained, to be very reluctant to engage in dialogue about the quality of health services in detention. And in fact, one very large funding body has said to me that they would not touch it with a barge pole, that being healthcare in detention, because it might be misconstrued as tacit affirmation of the system that they're trying to dismantle. And so we were very concerned about that. And we wrote this paper in the Lancet Child and Adolescent Health, pointing out that really is a false dichotomy with very significant consequences for children. So we said this, given the harms associated with deprivation of liberty, of course, every effort should be made to minimize its occurrence, but those efforts should not, and in fact must not, come at the expense of a commitment to the highest attainable standard of health in detention. To do otherwise would be to compound the health inequalities experienced by the most vulnerable young people. So in other words, of course, we should be minimizing deprivation of liberty, but if that comes at the expense of caring about healthcare in detention, it's a double whammy. We're further marginalizing the most marginalized children. So the health chapter in the UN Global Study, not surprisingly, argued that we need to think in a life course perspective. So in other words, children in detention are not a separate population. They are, in fact, and obviously, members of our community who pass briefly through episodes of detention before returning to the community. In Australia, the median time in youth detention is 8 days. So really, this is a blip in the lives of marginalized and at-risk young people. So the UN Global Study recommended for improving access to health services before children have contact with the youth justice system, diversion for children with health-related needs at the point of contact, critically improve quality and continuity of care for children in the system, and investments in care after contact with the system. And of course, building the evidence base under that to ensure that all of that's actually working. So from that emerged another terrific document that I commend to you, much shorter than the UN Global Study. This is a policy brief produced by the WHO, focused on health concerns among children deprived of liberty. Again, not exclusively children in youth detention, but those are definitely a focus. And the two things I want to draw your attention to, this is definitely worth a read if you're interested in this area. The first is this ecosocial framework that you can see in the top half of this figure, the idea that we can't just think about the child. We need to think about their relationships, about the community context in which they sit, and the broad social and structural issues that underpin all of that are really critical drivers of their health and welfare outcomes. And the other conceptual underpinning of the WHO policy brief was this life course perspective, a recognition that detention is a brief blip in the lives of marginalized young people who come from and very often return to very challenging circumstances. And to change the health-related trajectories of these young people, and indeed the justice trajectories, we need to think in that way. It doesn't really matter what we do in detention. It's not going to be sufficient in and of itself to create sustainable improvements in the life of young people. It's a great start, but in and of itself, it's not sufficient. So that's the ecosocial perspective. That's the life course perspective. And so from that, I just wanted to draw your attention to a few of the recommendations in this policy brief, and they're very sensible. And again, if you're interested in this area, I'd encourage you to have a look. The first recommendation is to focus on health protection and promotion, not just reactive care, but health promotion within detention facilities for children. And you'll see there the language that WHO used, it consistent with the UN Global Study, is that children are entitled to the highest attainable standard of health. They refer to the principle of equivalence, which is it's a reference to the UN Nelson Mandela rules that apply to prisons, but not youth detention. Rule 24.1 of the Mandela rules explicitly requires equivalent care for people incarcerated as adults. They also, in the context of the time this was published, talked about the importance of being mindful of mental health issues when applying quarantine and isolation in response to COVID-19. But of course, those issues around isolation are still relevant today. WHO also, recognizing that life course perspective, talked about the critical importance of follow-up after detention. So our responsibility to these young people does not end on the day they walk out of the youth detention facility and return to the community. And that means release planning before release, transitional care around the time of release, and reintegration support and assistance after release. Now, none of this seems surprising or rocket science, and yet remarkably, it very, very rarely occurs, including in Australia. As a researcher, I was pleased to see that WHO also called for improving the evidence base, and the evidence base with respect to the health status of children in detention, healthcare in detention, and health and other outcomes after detention. And of course, critically identifying the importance of ensuring that children's voices are heard, that it's not a bunch of old people telling young people what should be important to them or how they should obtain access to health. So that's the policy framework. And just to give, I want to share with you just one piece of research evidence to highlight how we're going in this regard. Now, our group has undertaken the first study to comprehensively look at any health outcome after release from youth detention in Australia. In this particular study, working with Youth Justice in Queensland, we linked youth justice records for just under 50,000 young people with the National Death Index, looking at every young person who had contact with the youth justice system in that state over a 14-year period. Now, what you can see here is we've disaggregated their survival, which is, do they continue living, by their level of contact with the youth justice system. The blue line at the top there is children who were only ever charged with an offence. These are children who were never convicted of anything, never sentenced to any kind of order, and most certainly never detained. So those children had a risk of death more than 3 times higher than other children in the community in Australia. Children who had served a community-based order but never been in detention had a risk of death more than 4 times higher than other children in the community. And the subset of children who'd experienced youth detention had a risk of death more than 6 times higher. So really the point here is these are extremely grim findings. This is not a 20% increase in risk for children in detention. It's more than a 600% increase in risk. And it really points to the absolute failure of our systems to provide the kind of ongoing care that children who have contact with the youth justice system need to prevent these tragic outcomes that are unfortunately very predictable. So just before I hand over to Tess, I'm going to give my completely legally ignorant framework around this. In the context of all of this work that we were doing, the UN Committee on the Rights of the Child published General Comment number 24, which was an elaboration on the Convention of the Rights of the Child with respect to what they called the child justice system or the youth justice system. And the one particular clause that concerned us was clause 108, which you can see here, and I've obviously highlighted the words that concern me the most. Every child has the right to be examined by a health practitioner and to receive adequate medical care. And I just want to contrast that with the language used in the UN Global Study and the language used in the WHO policy brief, which explicitly and unambiguously enshrines every child's right to the highest attainable standard of care, and which points to the notion of equivalence. In other words, children in detention shouldn't just get adequate care, but should get care at least as good as children in the community. So just to ram that home before I hand that over to Tess, I just want to very crudely characterize this as a 2x2. If you're an adult in the community, your right is to enjoyment of the highest attainable standard of health conducive to living a life in dignity. Under the Mandela rules, if you're an adult in prison, you should enjoy the same standards of healthcare that are available in the community, this principle of equivalence. If you're a child in the community under the CRC, you enjoy the highest attainable standard of health. But if you're a child in youth detention, you just get adequate care. So now this may seem like we're playing with words, but as I'm sure you've been aware, there's been a lot of concern about the adequacy of investment in healthcare for children in youth detention in Australia. And so I think these words matter. They really do provide the floor below which our authorities can't fall. Tess, I might hand over to you now.
Absolutely. Thank you, Stuart. And thanks everyone for joining us. It's an area of great passion for us. And so wonderful to be here and speaking about this. But as Stuart mentioned, building on the global study on the rights of children deprived of their liberty, the UN set up an interagency task force, a multi-agency task force called the UNTF, with members across several key UN agencies. As part of their mandate, they have the implementation of the global study on the rights of children deprived of their liberty. And that includes the right to health. So to support them in their work implementing the global study, we analysed the standards across all settings in which children are deprived of their liberty. So that's children in prisons with their primary caregiver, children in detention in the administration of justice, children living in institutions, and in children in the context of armed conflict and on national security grounds. And so what we found in our quite detailed report is that there is significant ambiguity across these different settings, but in particular highlighting the ambiguity that Stuart has pointed out in relation to children deprived of their liberty in the administration of justice. And so we're going to focus here on that particular setting, but did want to note that the report goes into kind of the broader detail across that broader set of settings. So we prepared this timeline just to show what we describe as the diminution of the standard required for healthcare for children deprived of their liberty in the administration of justice. So as Stuart mentioned, all children retain the right to the highest attainable standard of health under Article 24.1 of the UN Convention on the Rights of the Child. But there is ongoing ambiguity, we would say, in relation to how this applies to children deprived of their liberty in the administration of justice. So 1955, the original the original minimum rules for the treatment of prisoners were passed and were established, sorry, and set a low bar, saying that the right to health, or setting the right to health as that children should be, that people in prisons have a right to available services of at least one qualified medical officer. So kind of not that sort of broad approach to the right to health that exists in these other conventions. 1985, the minimum rules for the administration of justice were established, the Beijing rules, which state that juveniles in institutions receive all necessary assistance, social, medical, physical, that they may require. And also states that prisoners shall have healthcare available as far as relevant, so not that high standard that we now see in the Convention of the Rights of the Child, which was then ratified in 1989, clarifying, as we said, that the enjoyment of the highest attainable standard of health is what all children have a right to. Moving forward in the timeline, we've got on the timeline here, sorry, the Convention of the Rights of Persons with Disabilities. And then in 1990, the rules for the protection of juveniles deprived of their liberty, the Havana rules, were adopted, which, as Stuart pointed out, established the right to adequate medical care in Rule 49. So that lower bar was set in the Havana rules in 1990. Since then, there have been several key documents produced by the World Health Organization, including the WHO Prisons and Health Guide, which really underscored the importance of prison healthcare, but didn't talk about the particular context of children deprived of their liberty, and so failed to really demonstrate the need for that high standard of health, which, as Stuart has pointed out, is a critical point of intervention for children coming into the system. Then in 2015, the minimum rules for the treatment of prisoners were updated in recognition that the 1955 rules were outdated. And the updated Mandela rules provided specific guidance that said that people in prisons should have the same standard of healthcare that's available in the community. And as Stuart points out, words really matter here. This question of the principle of equivalence, which was established in the Mandela rules, is a critical policy issue when it comes to thinking about what services are actually available for people who are detained. Circling forward, 2019, so at the same time that the global study was being written, as Stuart points out, General Comment 24 was published, and it failed to update that standard as had been done for the Mandela rules, and instead enshrined the adequate medical care standard in General Comment 24. And then in 2019, the global study was presented to the UN General Assembly, and as Stuart points out, really highlighted the poor health outcomes of children in detention and really argued for the need for that principle of equivalence to be applied to children in this setting. So our concern overarchingly being that the standard of adequate medical care seems to have, at this point, have become accepted as the norm in the General Comment 24. And so sorry, I've gone on a little bit here, but our report demonstrates that in quite some detail and points out, in the context of what we know about the poor health of children in detention, that this is an issue that really needs to be rectified. So our report recommends that the Committee on the Rights of the Child clarify that all children, including children in detention settings or children deprived of their liberty, have a right to the highest attainable standard of health, and that health services in detention be equivalent to those in the community. So adopting that standard that's explicit in the Mandela rules. We also recommend that the Havana rules be updated to align with the Convention on the Rights of the Child, the Beijing rules of 1985, the Convention on the Rights of Persons with Disabilities, and crucially, the Mandela rules. So enshrining that critically at the highest standard that was clarified in the 2015 update to the Mandela rules. We also took the opportunity to make some recommendations about other important reforms in this space, including commissioning and collaborating on research into the health status of children in detention, which, as Stuart has pointed out, there is a dearth of evidence about what actually is the status of the health of children in this setting, and a real need for research to tell us exactly what we're dealing with, because, as Stuart often says, what gets counted gets done. We need to know the scope of the problem of what's happening in these settings in order to be able to move forward and make a real difference. There also needs to be research around healthcare availability and the delivery of healthcare. So in the Australian context, for example, we know there's a huge overrepresentation of Aboriginal and Torres Strait Islander children in detention settings. And yet, in most jurisdictions, Aboriginal community-controlled providers are not involved in the provision of healthcare in this setting. And we've done some work with Danila Dilba, which is an organisation, an Aboriginal community-controlled health service in the Northern Territory that's delivering healthcare in Dondale, and there's an Aboriginal community-controlled health service delivering healthcare in Alice Springs. And however, across the rest of the country, Aboriginal community-controlled providers are not involved in the delivery of this healthcare. Oh, sorry, I should also say Wononga in the ACT is also delivering healthcare to people in prisons in certain circumstances if they agree to, or if they request that healthcare. But again, underscores the point that there needs to be research and more transparency around what healthcare access is actually available. Also, critical recommendations around health governance and financing in detention settings, and further research around mortality, which obviously Stuart and the Health Justice Group have been working on, and importantly, mechanisms around improving health outcomes before, during, and after detention, as Stuart points out earlier. And then we also recommended the development of technical guidance documents to support the implementation of healthcare standards in detention, because there needs to be information for states in determining what the highest attainable standard of healthcare is and what the community standards are, and ensuring that when that's actually implemented in these settings, it takes account of the complexities that exist often in these operating contexts, but also critically the crucial needs of these children. And as Stuart points out, we've got a developing literature base around the health needs of children in detention, and that really needs to be informing the way that providers are providing care. And we also recommended adapting the World Health Organization's monitoring of health status in European prisons for all settings where children are deprived of their liberty. So again, that critical importance of oversight and monitoring in seeing what's happening and using that as a base for improving the system. That's the end of our slides. I might pass back to Stuart to add anything that I might have missed. And yeah, grateful for the discussion and looking forward to some Q&A.
Thanks, Tess. Yeah, look, and just to add very quickly with respect to the WHO, there's a collection now that's happening every few years in the European region where the WHO collates information on prison health across all European member states. And there's been for quite a while an aspiration to make that a global collection. And there's been lip service to expanding it also to youth detention, but I think that there's an increasing shift from lip service to a genuine interest in that, and documents like the one that Tess led around this work really help to move the dial on that. So the idea here is to really highlight the fact that children in detention are deserving of the same quality of healthcare as every other child, which seems obvious, but sadly is rarely the norm. Look, I think it's probably time to hand over to John, but I've just put, for anybody who's interested, there's a QR code. If you get your phone and scan that, that will take you to a link for the report. If you want to read the full report, it's available on the Harvard FXB Center website. So I should probably leave that up for a moment for anybody, but if anyone doesn't have it and wants it, please let us know. Perhaps we can put it in the chat. And just lastly, before I hand to John, a plug as well for Tess is very kindly giving a related presentation for us this Friday as part of the Australasian Justice Health Network webinar series, doing some work that I think built on this global work, Tess, which is focusing on healthcare access and quality in youth detention in the US. So look, and again, there's a QR code there for anybody who wants to join that Zoom call at midday Friday Melbourne time. So that's it for shameless plugs. I might stop sharing now and hand over to John.
Thanks so much, Stuart and Tess, for your wonderful insights. I'm always excited to hear people talk about children's rights, and particularly those in detention, having worked in that space myself as well. So thank you for your insights and for the work you're doing. I think it's really important. Sort of goes to my first observation, those online, is the issue of visibility. So we're talking about a cohort of people who are marginalised because of their age, then made invisible because of their status in detention. And then you add in the dilemmas associated with their health needs as well. So this is an exceptionally vulnerable group, which then makes, in my mind, exceptionally targeted and special measures, in fact, which I'll come to as well. So, I think the work that obviously Manfred Nowak did with his big study, WHO is doing, and now the work you're both doing is really critically important to just making this issue visible. And of course, this group here are all probably sharing the same view that more has to be done, but the reality is that that view isn't shared by most of the world when it comes to this cohort of children. So they're not the cute and cuddly ones. They're the folk devils, to borrow to language for the 70s, when we thought the harm that these young people pose to ourselves. And of course, in a law and order society, whether it's in Australia with, our media working to sort of obviously demonize these young people, or in America where the same approach is taken, there's some serious political challenges for us in elevating not just the legal and moral framework, but also the relevance of the evidence and getting the funding as well to actually support those claims. So that's something we might think about. How do we actually frame this in a way that actually has impact? Because, as Tess would know, America's justice system is it's pretty grim in many spaces, and ours is fine. My colleague Anna Hollands has undertaken a study here around youth justice because she was so alarmed at what she saw when going into the prisons in this country as well. So that's the first observation. The second is the complexity of health needs, and that then goes to how on earth this has come to play, and to what extent is the justice system actually exacerbating those conditions, or to go to the point that Stuart made about how do we be far more preventative in terms of what we're doing, so we're avoiding any engagement at all with the authorities, let alone issues of diversion as well. So complexity of health needs sometimes can be obviously part of what the individual brings into the world, but often, of course, a result of social determinants of health as well. So this conversation for us is around often what happens at the really pointy, thorny end of when they come in contact with the justice system. But in fact, there's a big conversation that precedes this as well for those who work in this sector around, and it's, I think you made the point about the ecological approach, Stuart, this idea that it's not just the individual child, it's the entire setting which that child finds themselves. And I think, again, we all understand that, but I'm not sure that always our policymakers see that or need to act earlier to allocate the appropriate funding to prevent that first engagement that we see, around 8, 9, 10, 11, 12 with the justice system. And of course, the absolutely disastrous outcomes that invariably follow as well, which is what your data sort of elaborates on as well. The third observation before I finish is then, of course, Tess's legal analysis of the framework. And of course, that's the stuff that I work on as well. And, it's really disappointing. The committee, my guess says Tess didn't really pick that up, to be brutally honest, having worked in this space. But what it does is it just draws the conversation down to a point where adequate, what does that actually mean? And so we run the risk of not having the language and the standards that the international body should be obviously advocating to then allow us who work in this space to be pushing those agendas at the local, at the regional and national levels as well. So that's a real dilemma for me. And it doesn't surprise me, having worked in this space, the committee often gets it wrong in terms of the language it uses, and as a matter of law as well. So, I've got an easy response for you if you're looking to sort of push this agenda as well. The language of the Convention, Article 4, talks about the obligation to take all appropriate measures. Okay, that's a higher standard, because what it means is you've got to have an evidence base that suggests that, in fact, what you're doing is effective in meeting its object and purpose. Okay, so this is where you see the magic of law and medicine combining, because I don't know what appropriate is as a lawyer, but Stuart, as a health professional, can tell me what measures and what evidence is required to actually meet the health needs of those children. And so, you know, adequate, not actually legally the appropriate term at all. Appropriate is the baseline. And then we talked about the principle of equivalence. I'd actually go a step further, in fact, and say that when it comes to children who are in particularly vulnerable situations, like children in detention, is actually need to take additional special measures, targeted measures, to actually address their health needs to ensure what we do is appropriate as well. So I'd be encouraging you to think beyond equivalence. That's our bottom line. Okay, that's what they're entitled to as a matter of right. But in fact, if you look at what the convention talks about in terms of obligations around non-discrimination, it's also around the positive obligation to take special measures to actually ensure that those children who find themselves in particularly vulnerable circumstances are able to enjoy effective protection of their rights as well. So just want to throw that in there as another limb to your arguments around how we address what the committee's failed to do, but also act for something a bit more than equivalence, I think, because I think that sometimes isn't enough, particularly for the complex health needs that these young people experience, which are very different to what we might see in the general population as well. So I'm going to end it there to prompt the conversation. I know I've got some colleagues online. One of my students may have left now. She's actually a doctor who worked, Bronwyn's there, a doctor who has worked in prisons, is now studying law. So I'll hand back over to Paula to do the Q&A. But thanks again. It is really reassuring, to be brutally honest, that people care about this stuff, because not enough of us do. So thank you for your contributions and insights, and for the work you're doing as well. It's great. Thank you. Over to you, Paula.
Thanks, John. And thanks, Stuart and Tess, for a fantastic presentation, giving us lots to think about. And John, thanks for your comments as well. That was a fantastic way to round out the presentation and open up this discussion session. So Stuart, why don't you go first? You've put your hand up, so.
Yeah, thanks, John. I really appreciated your comments, and I just wanted to, it prompted a few thoughts I was just hoping to really quickly share. And I completely agree that equivalence, it shouldn't be the same. There's actually a terrific paper by Rick Lines from about 9 years ago now with respect to prisons, making the provocative argument that people in prison deserve a higher standard of healthcare than people in the community. And it's a provocative way of making this point, that equivalence is with respect to the complexity and the health burden. So absolutely 100% agree. With respect to the Committee on the Rights of the Child, we actually put a submission in with regard to that particular clause, and they just didn't respond to it. And I had the opportunity to speak to the chair of the Committee on the Rights of the Child in New York about a year after that. And my sense, I'm not speaking on behalf of anybody else, of course, is that the problem is that the language of these documents typically is lowest common denominator language. And that's the concern, that once you enshrine language like adequate, it's very hard to raise the bar again. So there's that. The last thing I just quickly want to say to kind of concretize this in the Australian context is a terrific example from about a couple of weeks ago, when the leader of the opposition in the NT, the Country Liberal Party, was talking about spit hoods in youth detention, which are now fortunately banned. And she's proposing to bring them back because the rights of correctional officers and police shouldn't be held higher than the rights of young offenders, was her language. And so, language like that can occur in the context of a failure to appreciate the rights of children to at least even adequate care in that particular context. But thank you so much, John. You really got me thinking.
Thanks to each of you, Stuart, Tess and John, and thanks to everyone for coming along to the seminar and for your contributions. Helen will be back with another seminar on the first Tuesday of next month. That's our regular time, but we just made a change because of school holidays and Easter this month. But please join me in thanking Stuart, Tess and John. Thank you very much.